How are you all doing today? Good. Raise your hand if you've been here before to one of our symposiums. Look at that turnout. Fantastic. If you've never been here before, I just want to welcome you. So we're so glad that you're here. Maura mentioned in her discussion that, it takes a team. And part of that team is you getting together and meeting other people. And I know that we help you to do that through our symposium. The other part of that is the speakers that we involve in our programs. So I'm really happy to be a part of WPA. We do have a lot of new programming that's coming out this year that I'm very excited about. I'm very excited too about our panel discussion this morning. We've got a medical panel of experts, and some of you may know them. We try to get people throughout the state who are specialized in Parkinson's disease to give you some of those grains of salt and pearls of information that you can take back home with you again. So I'd like to welcome our speakers today. We have Dr. Brian Nagle, Ariana Frisch, and Dr. Eric Jackowiak. And so I'm going to head right into that program if you don't mind. First off, we have Dr. Brian Nagle. He is from UW School of Medicine and Public Health. And Dr. Nagle attended medical school at the University of Central Florida in Orlando, Florida. His residency was in neurology at Georgetown University. He completed his fellowship at Georgetown University. He is Badger alumni and recently returned to Wisconsin to practice neurology at UW Health, seeing both general neurology as well as people with Parkinson's disease. He has special interest in treating patients with Parkinson's disease. So please give a warm welcome to Dr. Brian Nagle.
Okay. Well, thank you all for having me here. It's a pleasure to meet everybody. And I'm really excited that we're here to talk about non-motor features. I think in Parkinson's, oftentimes the motor features kind of take, the spotlight, but oftentimes the non-motor features can impact patients' quality of life just as much. So I'm going to be focusing on a select few here. So I'm going to be talking about some sleep-related symptoms, including REM sleep behavior disorder, problems with insomnia, and then we'll move on to talking about drooling or sialorrhea, and finally talk about some urinary symptoms before I pass it along to my colleagues. So REM sleep behavior disorder is essentially kind of acting out your dreams. So REM sleep, or rapid eye movement sleep, is typically when we do a lot of our dreaming. And typically what happens is that when we enter this state, our body goes into a state of paralysis to stop us from acting out our dreams. Now, in Parkinson's disease and related disorders, this switch doesn't work properly. So people can act out their dreams, and that can be anything like kicking, talking, yelling, punching. And sometimes it might come off as a little bit kind of silly and people kind of brush it off, but it can be dangerous because it can also cause people to jump out of bed. And you're jumping out of bed while you're asleep, so you're not aware of your surroundings, and that can increase the risk of falls. It can also be dangerous for the sleep partner, so there have been instances where people have been, kind of punching their significant other who's sleeping next to them. It's also often associated with vivid dreams as well. In the picture below, I have what we call a sleep histogram, which is essentially just kind of shows the normal sleep architecture. So REM sleep behavior disorder can also disrupt the quality of sleep because we have to go through these natural stages. So you go from stage 1, 2, and 3, and then REM sleep. And you kind of continue this cycle throughout the night. And what happens is that if your sleep is interrupted for any reason, it can be, somebody a dog barking, or a person kind of waking you up. It can be snoring due to sleep apnea, but it can also be due to waking up because you jolt yourself awake because of some of these actions. What happens then is you have to start back at square one and start at stage 1 again. So that can interrupt the normal pattern that we have in our sleep and affect sleep quality as well. And what we know is that REM sleep behavior disorder can be a premotor symptom that people have long before they ever develop any of the slowness of movements, tremor, muscle rigidity. In those who have premotor REM sleep behavior disorder, about 70% of them will be diagnosed with Parkinson's disease by about 12 years. And it affects about 33 to 46% of patients with Parkinson's disease, so it's not an insignificant number. It may also be a risk factor for neuropsychological and functional deficits as well. So how do we go about treating this? What I typically talk with patients about first is kind of starting with some of the more mild treatments first. So starting with over-the-counter supplements like melatonin can sometimes be helpful for reducing the acting out of the dreams and the vivid dreams. But sometimes if that's not enough, then we add in a low dose of a benzodiazepine called clonazepam. Okay, moving on to insomnia. So insomnia is a difficulty with either initiating or maintaining sleep. What can often be helpful in these instances is keeping a sleep journal. And that can be helpful because it kind of, and it doesn't have to be, you don't have to be keeping a sleep journal for months on end. Just like a week sample is usually enough. But just to kind of, log things like, when was the last time you had caffeine? What time do you go to bed? What time do you fall asleep? Or what time do you think that you fell asleep? How many times are you waking up during the night? What wakes you up during the night? Is it to urinate? Is it just that you wake up and feel restless? And then how easy is it to fall back to sleep? And that can be very helpful because it can help show us some patterns. Because what we can do by determining the timing of awakening is that we can sometimes see that there's a pattern that shows up. And so for those who are on a medication like carbidopa-levodopa, as that medication is wearing off, people may wake up and have this kind of internal restlessness that we call akathisia that prevents them from falling back to sleep. You take another dose of your carbidopa-levodopa in the middle of the night and raise your dopamine levels up and get back to sleep. So it can sometimes be a wearing off feature. If it's not a wearing off feature and it's more so due to difficulty initiating sleep, that's where adding melatonin at bedtime can be helpful. Sometimes if it's a matter of not having a long enough duration of the carbidopa-levodopa at night, there are some controlled release or extended release formulations as well that can also be helpful to take at bedtime. Now, drooling, we often, I think we kind of use the term drooling to refer to sialorrhea, but sialorrhea is really just an increase in salivation. And when you have excess saliva, it can go one of two ways. It can either go anterior, which is what causes drooling out of the side of the mouth, or it can go posterior, and sometimes this can go unrecognized, and people, complain of a chronic cough or frequent choking or difficulty with swallowing, and that can be because of excess saliva going posteriorly, kind of in the back of the throat. Sialorrhea or increased salivation can be due to kind of a combination of factors. As we know, Parkinson's disease can affect a part of the nervous system that controls salivation called the autonomic nervous system. But it also affects the speed at which people are swallowing. So sometimes it's a matter of, when people are wearing off, their swallowing reflex isn't quite as fast, and so they have increased drooling due to the low dopamine levels. How do we go about treating this? Well, hard candies or sour candies or lozenges can be helpful. It just kind of helps to stimulate that swallow reflex. But if that's not enough, then we can also use botulinum toxin injections, which are just some small injections that go into the salivary glands and help to dry those up. And that reduces the amount of saliva that's being produced. It can be helpful, especially if there is posterior, those saliva is dripping posteriorly, because that can increase the risk that it goes into the lungs and causes pneumonia. Now onto the urinary symptoms. So what I hear frequently from my patients is that there's urinary urgency, frequency, retention. I mean, it's kind of hard to kind of tie that in with the Parkinson's disease, but what we know is that the bladder is surrounded by a muscle, and just like the muscles elsewhere in the body, it can also be influenced by the dopamine levels. So just like there can be tightness in the arms and legs as dopamine levels are wearing off, that muscle around the bladder can also get tight. And what I usually explain to my patients then is that when the bladder muscle gets tight, it also makes the bladder smaller, so it holds less urine, so people are going more frequently because that storage capacity isn't there. And then when it's tight, it also is more sensitive to any kind of stretch. So you don't get that warning signal about the bladder kind of stretching and stretching to the point where, you know, you get a little bit of a warning and then you get more of a warning. It's like an all or nothing. So you get just a little bit of stretch and it sends that signal up to the brain that I gotta go right now. And that's where the urgency comes in. So one thing that can be helpful with this is monitoring again, you know, kind of getting back to similar to the sleep, monitoring the timing that this happens. So if it's happening more as it's getting close to the next dose of carbidopa-levodopa, it may be due to a wearing off phenomenon. So it can be kind of that on-off fluctuation. Oftentimes we're working, this is where it kind of gets back to kind of putting your team together. Oftentimes we are also working with urology or urogynecology to also come up with strategies for managing this. Physical therapy can also be helpful. There are pelvic floor exercises that the physical therapist can teach that can help with some of those symptoms. But working with the urologist or urogynecologist, there are some medications like mirabegron, vibegron, or trospium, which can also be helpful as well. In some instances, it does require some intermittent catheterization as well. So I will now hand it off.
Thank you, Dr. Nagle. I appreciate it. That was great insight. Next, we're going to hear from Ariana Frisch. Ariana is a board-certified nurse practitioner specialized in movement disorders at Marshfield Clinic in Wausau. She earned her Master's of Science in Nursing degree at Concordia University and her bachelor's degree at University of Wisconsin-Madison. She started working with movement disorder specialist Dr. Katie Spangler in 2016. Her mission is to provide personalized and empowering healthcare experience that enables patients to make informed, realistic decisions. She wants patients to understand and choose a healthcare journey that harmoniously reflects their life's journey, goals, aspirations, culture, and spirituality. Please give a warm welcome to Ariana.
Thank you. When I see Parkinson's disease patients in the clinic, I hear a lot of I used to's, with a quiet desperation in their voice to bring that person back. But despite the Michael J. Fox's Foundation relentless effort to find a cure, I still don't have a way to bring that patient back. And so with Parkinson's disease, we must continuously grieve and leave that person behind and enjoy the person you are today while accepting and managing the inabilities. I will discuss 3 of those possible inabilities today: constipation, neurogenic orthostatic hypotension, and some skin changes that can occur with Parkinson's disease. So with constipation is one of the most common non-motor problems associated with Parkinson's disease. It can be part of the disease itself or a side effect from the Parkinson's disease medications. Diarrhea can actually be part of constipation as the liquid stool kind of passes around an impacted stool. And it can affect how well the Parkinson's disease medications work because the medication needs to pass through the gut and absorb in a certain area of the gut to work. There are some non-pharmacological methods to try to manage constipation. Some of these include staying active, staying hydrated and increasing fluids, establishing a routine such as trying to have a bowel movement after a meal, not ignoring the urges to have a bowel movement, increasing your fiber intake, and actually using correct positioning. So I kind of have a picture of a guy there using the correct positioning. There's these things you can get online, squatty potties type things. So sometimes we use razors because it's hard to get up off of the toilet, but that actually can cause worsening constipation because you're not in the right position. So placing a device under your feet for a better position may be beneficial. There are several over-the-counter medications that can help. Usually Miralax is the first one we recommend, but again, it's very important that you increase your fluids if you are taking Miralax. A probiotic may also be helpful. In severe cases, a prescription may be needed, but usually these are prescribed by a gastroenterologist. Care needs to be taken when selecting an over-the-counter medication, as some can cause dependency or irritation to the bowel. I have provided a PowerPoint list of the different kinds of medications for constipation that you can review. This list is from the Parkinson's Foundation and the different kinds and the way they work. However, despite them being over-the-counter, careful selection should be made when choosing, as there can be contraindications when choosing one with certain health conditions. It is very important to remember constipation can be caused by other medical conditions like colon cancer, and never assume it's just part of Parkinson's disease. Routine colon cancer screening is recommended. Next, we'll talk about neurogenic orthostatic hypotension. This is a drop in blood pressure when changing positions, either from lying to sitting or sitting to standing. Its definition is a drop of 20 millimeters of mercury or more in drop of the blood pressure, or 10 millimeters of mercury or more with the bottom number of the blood pressure. There are many symptoms of neurogenic orthostatic hypotension, and some of them include dizziness, lightheadedness, blacking out or fainting, generalized weakness, fatigue, or cognitive slowing, headaches, trembling, nausea, hands, or even chest pain. A lot of times I'll have patients come in or call and complain of leg weakness, thinking it's a motor symptom. Really what it is their legs are feeling weak when their blood pressure drops. However, orthostatic hypotension can happen with many other health conditions, and Parkinson's disease does not exclude you from everything else. So it's always important to rule out other health conditions before assuming it's from Parkinson's disease. Now, there is behavioral mechanisms we can do to help with the symptoms of orthostatic hypotension. These include staying hydrated, not avoiding salt, using a correct blood pressure cuff and monitoring our blood pressures, changing positions slowly, elevating the head of the bed by 30 degrees, avoiding caffeine, carbohydrate-rich meals, and alcohol, avoiding hot environments and dressing in layers, and wearing compression stockings or even a possible abdominal binder. Getting regular exercise can also help. One way to try to prevent the drop in the blood pressure before you stand up is by doing some muscle contractions, such in the leg or feet, or even when you do stand up, to march slowly in place. A lot of patients are in a rush. They try to get up, they walk across the room, and what happens is as your blood pressure drops, you're in the middle of the room, you have nowhere to sit down, and you fall down. By standing up and giving it a few minutes, you allow your blood pressure to adjust. And if you do need to sit down, you have your chair behind you and you can sit back down and try again. I have recommended compression stockings to a lot of my patients, but I can honestly say majority of them probably don't wear them. They can be very hard to put on, and they can be really uncomfortable. In a perfect world, I would tell my patients thigh high is preferred, and they should wear them, but I'll be honest, probably a lot of them don't. So I would at least suggest knee high, but again, thigh high is preferred. There are these stocking donners that you can buy online to help apply these. If not wearing the compression stockings, you could try using an abdominal binder, which you can, again, find at any of your local stores, that again help kind of push the blood back up to the brain to try to prevent the drop. There is also postprandial hypotension, which is a form of orthostatic hypotension, when the blood kind of after we eat pools to the stomach, and again you have that drop in the blood pressure in the brain, which can cause those dizziness kind of symptoms. And so you can try eating smaller meals with less fat and adequate salt to try to help with that. Unfortunately, there are several of the medications that we use for Parkinson's disease that can either contribute or cause orthostatic hypotension. However, many of these can't be discontinued. It is important to remember it is the drop in blood pressure that is the problem. I have many patients who call me and say, but my blood pressure is great, it's normal, I checked it, or my blood pressure is even high. It is not the blood pressure when you're sitting there and taking it, it's the blood pressure change when you change the position that matters. You can even have orthostatic hypotension even when your blood pressure is high. And so, again, checking it with different positions. There are medications that can be prescribed to help increase the blood pressure, to help improve the symptoms by not allowing the blood pressure to drop so low. However, these should not be taken less than 3 hours before bed, as they can cause a dangerously high blood pressure when laying down. As with many medications, to increase the blood pressure need to be done with caution, especially with other health problems like ischemic heart disease, arrhythmias, and congestive heart failure. There are skin changes that can occur with Parkinson's disease. These include seborrheic dermatitis, dry skin or excessive sweating, increased prevalence of melanoma, skin cancer, and bullous pemphigoid, which is an autoimmune formation of large blisters, which I have kind of like a picture of that on the slide, as well as skin changes caused from medications or their treatments. So seborrheic dermatitis symptoms include scaly patches, red skin, or stubborn dandruff, especially on the scalp and the face. Things you can do to try to help with this include washing the skin twice a day with just warm water and rinsing with cold water, using a natural soap like unscented glycerin soap. For dandruff, you could try an over-the-counter shampoo, such as Head & Shoulders, or a shampoo containing selenium, selenium sulfide, salicylic acid, zinc, or coal tar. Sometimes when it's really stubborn, a prescription treatment can be for antifungals and topical steroids to help. For dry skin, you can use skin moisturizers and hair conditions, but sometimes a consult with a dermatologist may be needed. For excessive sweating or too light sweating, excessive sweating can be part of an off-time phenomenon, so maybe just adjusting your medication so you have less off-time to help with that. Other options can be to try taking lukewarm showers, wearing lightweight cotton clothes in warm weather, or dressing in layers, and staying hydrated. Other skin changes may include livedo reticularis, which is a side effect from the medication called amantadine. And that's the picture kind of on the lower right-hand side there, where you get some dilated blood vessels. You can also have surgical scars from, say, deep brain stimulator placement or from the Duopa pump in the stomach. There also can be skin irritation from injections, such as with apomorphine, or skin irritation from medication patches, like the Nupro patch. And as discussed previously in the last slide, you can have some irritation around the mouth from drooling. Also, there is an association between melanoma and Parkinson's disease. Research is ongoing to try to find what that link is, but it's important to watch the skin for changes that could indicate melanoma when you have Parkinson's disease. We do this by using the ABCDE rule. So we want to look, and first, and you can kind of see this up on the picture on the right, you can see that it's kind of asymmetric.
B is the border. You can see the borders kind of different colors. You look at the color, there's different colors within that. The diameter is big, and then we use involving. How is it changing? Those are all clues that it could be melanoma, and you'd want to get that checked out. In conclusion, until we find a cure for Parkinson's, we can collaborate to manage the symptoms and focus on enjoying the person you are today.
Thank you, Ariana. Appreciate that. Our next speaker that we're going to round out with is Dr. Eric Jackowiak. He's a neurologist and movement disorder specialist at the Medical College of Wisconsin and Clement J. Zablocki VA Medical Center in Milwaukee. He completed his neurology residency training at the University of Pittsburgh Medical Center and movement disorders fellowship training at the University of Michigan. In addition to clinical care for patients with Parkinson's disease and other movement disorders, he participates in clinical research trials and has published several research articles and case reports on Parkinson's disease and deep brain stimulation. He's also the director of the MCW Movement Disorders Fellowship Program and the Milwaukee VA Parkinson Disease Consortium Center. Please give a warm welcome to Dr. Jackowiak.
So thank you, Daisy, for that introduction. So before I start talking about my topic, I think it's maybe a good idea just to kind of stop and regroup. We just, heard very, detailed, excellent presentations on a lot of the non-motor symptoms of Parkinson's. It's quite overwhelming because it basically sounds like there's just this long list of things that Parkinson's can do, right? And, maybe coming in, like Dr. Nagle mentioned earlier, a lot of the focus or a lot of your thought is on tremor or movement problems, but there's just so many non-motor symptoms too. And so maybe this is eye-opening, maybe some of this is validation that these are some things that you've experienced. But I think it is important to think about, when we talk about non-motor symptoms, that these are highly variable, and these are all things that can happen, but they're not necessarily things that will happen to everyone, or the degree or the severity is different for everyone. And so just kind of keeping that in context. And I really say that because the topic I'm going to talk about is, quite uncomfortable and sometimes frightening to think about. So, kind of just going in, what I'm going to say is not necessarily telling you what's going to happen to you or what is happening, but, things that, might occur, and what we can do about it. So specifically talking about memory impairment or cognitive impairment, and then also psychosis, which is hallucinations and delusions. So kind of just overall, when we think about cognitive impairment in Parkinson's disease, we know that the disease itself can do this, can cause cognitive decline. It is important, though, to also look at other contributing factors. Some of these are Parkinson's related, some of them are not. So there are other things that can affect cognition. Sometimes vitamin deficiencies, like vitamin B12 or thyroid dysfunction. So these are things we commonly look for. So other non-Parkinson's related issues. But then a lot of the other even Parkinson's issues can affect cognition too. And some of these are sleep, like Dr. Nagle mentioned. If you're not sleeping well, your mind isn't going to work as well either. Mood is a big one. So, just having depressed mood or anxiety can actually affect the way that your brain processes information. And you can even get what we call a pseudo-dementia if from depression that can basically mimic dementia symptoms or cognitive impairment, but it's really, mainly being driven by depressed mood. Medications are important, so including some of the medicines that we give for Parkinson's, including, some for non-motor symptoms like the bladder. There are certain medicines, as Ariana mentioned, that can affect, that you might be prescribed to help overactive bladder that can actually negatively impact cognition. Some that might be given, say, for drooling, could potentially impact cognition. So these are things to keep in mind. And then even what we think about as the main motor treatments for Parkinson's disease, the dopamine medicines like carbidopa, levodopa, as that kicks in and wears off, so some people, at the peak, may feel their best, and then they're wearing off and start to feel more foggy or hazy. Other people, when the medicine is kicking in and at their peak, they actually feel a little foggy. So it's different for everyone. So it's important to kind of look at things with a detailed eye and try to see what all is contributing here. Besides those things, though, it is true that Parkinson's disease can cause cognitive decline just by itself. And so this kind of comes in two main categories that we define clinically. One is mild cognitive impairment. The other is dementia. The main differentiating factor there, dementia is basically just that the symptoms have become severe enough that they're starting to impact day-to-day function, be that social life, occupational life, just things that you have to do every day to take care of yourself. So when those things are being impacted by the cognitive changes, that's really when we define it as dementia. Unfortunately, this is something that, does happen as the disease progresses. It is usually not something that happens early on, though. So meeting that criteria for dementia is much more likely to happen in more of the later or advanced stages of the disease. So we wouldn't expect early dementia in Parkinson's disease typically. On the flip side, the mild cognitive impairment is, basically cognitive changes, but not that are reaching the severity to actually impact, at least significantly impact day-to-day function. And this is actually something that is not uncommon even in early Parkinson's disease. And it's something that I think, maybe sometimes gets ignored or that you don't want to think about it, but it is important to think about and address. Some of the things we see in this could be trouble with, say, just planning or initiation. A big one that we see is processing speed too, that, the information, it's up there, your ability to take in information and respond, it's all there. It just goes a little bit slower, just like, motor movements get slower in Parkinson's, that cognitive function gets slower too. So this is quite common even in earlier Parkinson's. Even though we're not calling it dementia, it is, important to realize that this can have negative impacts. It can affect work. So people who are still employed, going to work, even though they may be able to do their job, maybe, just doing it a little bit slower, or maybe need to have a little bit, take extra steps to kind of organize how their job is done. There can be some negative stigma associated with that. Other people, might look at that and kind of attribute it to just kind of being lazy or stubborn. And I mean, and I know that that's not the case, but unfortunately it can be perceived as such. The other thing, even in the mild stages, it can affect, relationships with family and caregivers too. So certainly don't want to ignore that. Thinking about treatment for these symptoms, I think the first thing that I do is kind of look at the things that I talked about first. So are there other contributing factors that can be addressed? So can sleep be addressed? Are there medicines that we are giving that are actually negatively impacting the memory and thinking? can we discontinue those or switch to other treatments? There are medicines that we can give that do at least have some evidence for, improving, the cognitive function and even sometimes behavior and might impact quality of life. So there are some medicines that we can give there. The evidence of the data in those is really just using those in the dementia stage, not so much in the mild cognitive impairment stage, but they are out there. So there are some things that we can do. I'll move on and kind of talk about the next topic. So psychosis and Parkinson's disease. So psychosis really is it's a broad term that there are different types of psychosis under that. So this includes hallucinations. So these can be visual, seeing things that aren't there, auditory, hearing things that aren't there. Can be delusions as well. So these are beliefs in something that are not true. And then even illusions, or that you might, think, you interpret something as something else. So like you see a tree and then see it as a face or something like that. So these are different types of what we consider psychosis in Parkinson's disease. This is, just like dementia, not something that we expect to see really early on, but does occur as the disease progresses, is more likely to occur anyway in more advanced Parkinson's disease. And actually, there's a fairly significant association between dementia and psychosis. So unfortunately, sometimes these two things tend to come together. Just like cognitive changes, just like dementia, we have to take a hard look, are there things that we are doing that could be contributing to this? Unfortunately, a lot of the medicines that can contribute to dementia or cognitive change can also cause hallucinations. And then the big one, unfortunately, the medicines that we give to treat tremor and slowness and rigidity, the dopamine medicines, can make hallucinations worse. And so a lot of times we have to end up kind of, balancing the treatment of the two issues. There are, though, if we're not able to take away medicines or change that, there are treatments that we can give to suppress hallucinations if we need to. Now, before I say that, there are a lot of times where the hallucinations may actually not be that big of a deal. I know that's weird to hear or see. Maybe they're really mild. Maybe the person understands that they're not real. Maybe it's just seeing occasionally a little animal that runs on the floor, or something like that. And that's maybe not actually causing that much problem or that much disability day to day. So in that case, we may decide that, this maybe isn't something that we need to give another medicine for. However, if it is troublesome, or say they're threatening or scary, or the person doesn't realize that they're not real, and that's causing them to act on those hallucinations, there are some medicines that we can give. We just have to be really careful. And so this is one that if a neurologist isn't prescribing these for you, you want to make sure that this is not something that's going to worsen other Parkinson's symptoms, because a lot of the traditional antipsychotic medicines that are used in psychiatry can actually worsen other issues in Parkinson's disease. So there's a very short list of things that we can actually give for this. So I think, to save enough time for questions, I'll just move on to the last point here then. And this is really just terminology, and I think there's a lot of confusion or questions I get about, just diagnosis and the terms dementia with Lewy bodies, Parkinson's disease dementia, Lewy body disease, and just kind of confusing or asking, well, what do I actually have? What's my diagnosis? And if you're confused about this, it's because medicine is confused about it also. Nobody really, or there's a lot of disagreement and controversy about how we define these things. And at its core, dementia with Lewy bodies and Parkinson's disease dementia are basically the same underlying pathology. So Parkinson's disease has Lewy bodies. It's the same issue. And we kind of use this kind of arbitrary cutoff that we say if the dementia happens within a year of the onset of things like tremor or motor symptoms, then we call it dementia with Lewy bodies. Whereas if the dementia or psychosis hallucinations come later on, then we call that Parkinson's disease dementia. It's an arbitrary cutoff, it's really just based on, opinion on how we define these things. Ultimately, at the end of the day, the treatment is really pretty much the same though. And I'll say there is a movement of people out there that are pushing to even get rid of this distinction. You might hear different opinions on this depending on who you talk to, but just wanted to kind of clarify that if you're confused on some of the terminology there. I'll stop there, I think, so we have plenty of time for questions.
So I wanted to just kind of round that out a little bit before we move on to the Q&A part, that the point that Dr. Jackowiak made about the fact that not everybody gets everything. I always say to my patients, Parkinson's is like a pot of stew and you don't know what you're going to get on your spoon. So yeah, keep in mind that all these things that we're talking about aren't necessarily going to happen to everybody. With the regards to the medications that we talked about, Dr. Jackowiak and Ariana both hit on the fact that there are certain medications that can induce some of those problems. The WPA puts out 2 contraindicated drug cards, one for people with Parkinson's disease, so those are all dopamine lowering agents that can actually worsen Parkinson's disease, and then a second one is a contraindicated medication list for people who are having cognitive disorders, and those are bladder medications and such, and there are a couple of Parkinson's medications on there too. So we do encourage you to carry those cards with you if you're having that issue. Again, if you're not having cognitive problems, you don't need the cognitive card, but there are 2 separate cards. And we are actually working on absolutely the final edits to that, to actually revising that card. Actually, Dr. Brennan has it on our medical advisory committee, and we're just getting that finalized. So there will be an updated card because there's updated medications, and we always have to be cognizant of that. So just know that we do put those out through the Wisconsin Parkinson Association, and it is something that's distributed. We try to get it out to the providers so that they can give it out in their clinics, and then also at the support groups. Your facilitators should have copies of those as well. So I appreciate you all just bearing with us for a minute. What we're going to do is first, if you want to go back to Dr. Jackowiak's slide, if that's okay, I wanted to hit on the fact that he is involved in clinical trials, and we actually have, there should be a QR code, a slide with a QR code. Sorry. It's in your book. Yeah, it's in your book. I was going to put it up on the screen, but if we don't get it on the screen, that's okay. So that QR code is for the clinical trials that are conducted at Froedtert and the Medical College of Wisconsin. And if you're not familiar with QR codes, what you do is you open up your phone to take a photo, as if you were going to take a photo, and you hover over that QR code, and it'll automatically just kind of take you to that link. And that'll always be updated. So if you're interested in any clinical trials, we also do have information at our WPA table right where you got your bag. And also, you can pick up some pamphlets there if you're interested in clinical trials. So we're going to open up discussion, if you don't mind. We're not going to obviously take everybody's questions. If you have a question for one of the panel members, we do have runners in the audience, and so just put up your hand if you've got a question specific to non-motor symptoms of Parkinson's, and they'll be happy to bring you a microphone. And then the runners, just raise your hand if you've got somebody there that's ready with a question. And let us know who the question is for, too.
Probably for Dr. Jackowiak, although all the practitioners are welcome to respond. Two things. First of all, can you distinguish between hallucinations and Charles-Bonnet syndrome, and what can be done about that? And the second thing is this card with the medication list that you talked about a moment ago. Is there an app that we could download to our phone? Because that'd be a lot easier than carrying it around in a wallet.
All right, so thank you for the question. So if you don't mind, I heard it was about the hallucinations, right? And then I missed the in which syndrome? Very interesting question. Very interesting question. So Charles-Bonnet syndrome is not something that is traditionally linked with Parkinson's disease. So what that is people with vision loss can actually get hallucinations secondary to the vision loss. So I kind of think about it as the brain is not getting enough input in, and so it's kind of creating these images by itself. It's filling the void. So this would be, in my opinion, probably a little bit of an unusual scenario to have both of those things together. I don't know if you guys have seen that before. Yeah. And then the second question about the app, I'll let Daisy answer that. Is there an app, or going to be an app for the medication contraindicated list?
Okay. That's a good question. You know, we're always looking to try to update our materials and things, right? At this time, there's no app for it. It is on our website. So on our website, we have those contraindicated medication cards, and you can actually print that out. Mm-hmm. Question?
Exactly what are Lewy bodies?
Say that again, sorry.
What are Lewy bodies?
Lewy bodies? Mm-hmm. Mm-hmm. Yes.
Yeah, so sorry I didn't explain that further. So Lewy bodies are what a pathologist, looks at under a microscope, looking at brain tissue, and how we define, the Parkinson's disease. So basically what it is a collection of protein, specifically a protein called alpha-synuclein, that's just not supposed to be there. And so it collects, and then you can see it under the microscope. So those are called Lewy bodies.
This is for Dr. Nagle and Dr. Jackowiak. How, the REM sleep disorder dreams where they seem very, very, how do you differentiate a hallucination versus what happens with those dreams that feel real but aren't real?
Yeah, no, that's a great question. And I think that kind of gets back to, kind of one of the common features with a lot of non-motor and motor symptoms is also kind of the timing that they happen. So it's not uncommon too for people to have, when people are talking about hallucinations, one of my first questions is to ask them, do they happen during the daytime or is this just at night? Because if they're just happening at nighttime, what can happen oftentimes with REM sleep behavior disorder is there's kind of this blurring of the lines between awake and sleep. And so when people wake up, their dreams kind of can bleed into reality. And so there's this vivid dream still occurring while the person is awake. And so sometimes by treating I treat those as REM sleep behavior disorder, and so use melatonin and clonazepam as opposed to using things like the antipsychotics for treating those. and that can help kind of suppress some of those vivid dreams that are bleeding into reality. Great question.
Hello, everybody. I want to thank you so much for the information that you're sharing with all of us. I am a Parkinson's, I wouldn't say victim, I'm a Parkinson's patient. And my wife has noticed a distinct slowing of my speech. And what I struggle with is not just short-term memory, but when I'm speaking, all of a sudden there are these gaps in my brain. I can't remember words that I've used for a lifetime. I'm wondering if there is some kind of treatment for that problem.
Yes, so what you described, the kind of you're speaking and then suddenly you can't find the word, or there's a pause or a gap, unfortunately is very, very common. This is not something, at least to my knowledge, that specifically the medications that I'm talking about for Parkinson's disease-related dementia clearly help, or not consistently help, I'll say that. And part of that is what you described, can be part of that more mild cognitive impairment rather than dementia. It's, many times this is the most bothersome part of the disease for people who have this issue. I actually like, referring even to speech therapy or speech language pathology, or trying some even non-medication approaches in this scenario. But unfortunately, there's not a quick fix or an easy fix for that necessarily.
Yeah, I'm not sure who's going to handle this, but what does the effect of donating blood have on the non-motor?
So just to repeat, make sure we understood. So what is the impact on the dopamine levels on the non-motor symptoms? Did I understand that correctly?
Yeah, for a person that's donating blood.
Oh, donating blood. I'm sorry. So I did mishear you.
I would think that kind of with Ariana's kind of topic is just being mindful that, if with Parkinson's your blood pressure may be sensitive to changes in position. So if you donate blood, just being mindful that it may impact that. So don't jump out of the chair and try to run out. Give yourself some time and see if it impacts. Make sure that you're staying really well hydrated.
I'm not quite sure who to address this to, but I was diagnosed 4 years ago with Parkinson's, and being put on the dopamine medication, I had a negative action from the medication, and so far I have been put on zonisamide, which is from what I understand, a anti-seizure medication that Japan has been using for about the last 20 years. I don't know what I would be like without it, and I'm just wondering if either any one of you would would be familiar with this treatment, with this medication. I guess that's my question.
Yeah, so my understanding with zonisamide is that it is used most often in neurology as an anti-seizure medication, but it does have some effect on, kind of similar to medications like rasagiline and selegiline. It has some effect on the monoamine oxidase, so it actually helps to decrease the activity of that enzyme that breaks down dopamine, so it helps to prolong the effects of the dopamine in your brain so that you're able to kind of continue to recycle it. So there are studies that have shown that zonisamide has some benefit in early mild cases and as an adjunct therapy even to carbidopa-levodopa.
One of the non-motor symptoms that you didn't mention. It's sleep issues. My wife has been having that issue, and I try to find certain patterns that exist, but I cannot find it because maybe 2 nights in a row she will have dormer sleeping, and then one night it just goes through the door. Do you know what's causing that issue?
Yeah, so we'll just restate the question. So basically asking about sleep issues. And
right.
And what it sounds like is that each night can be vastly different. Do I understand that correctly?
Yes,
I'm just asking.
2 nights in a row, it will be very consistent. And then comes one night, then, no sleep. Or the sleep become very inconsistent.
Yeah, so, I'll let Dr. Nagle comment too, but I'll say there's a lot of things, unfortunately, in Parkinson's disease where are not necessarily predictable. So, even though we know there's an issue, some days that can dominate your day. Other days, you have a good day. So that can be motor symptoms. That can be, a mix of non-motor symptoms. And I would consider sleep issues to be one of those. And so kind of, addressing, more specifically maybe what's, on the bad nights, what's actually happening, and trying to just get to the bottom of that and to address it more specifically.
Yeah, I agree. So, fluctuations are kind of the most consistent thing in Parkinsonism. So, the most predictable thing is the unpredictability. If it seems like there is some variations, one of the things that I always talk with my patients about is making sure to stay on top of constipation, because oftentimes, if people are having more constipation, then they're not absorbing their medications as well, and that can contribute to some of that variability in the results of their treatments as well.
Thanks. Over here. Hi. Thank you all for being here. I have a question specifically for Dr. Nagle. You mentioned melatonin as the first line kind of for sleep. What dosage are you asking people to start at?
Right. I usually tell my patients to start with 5 milligrams. And I usually say, give it a couple of, depending on how often the REM sleep behavior episodes are happening. If it's, only happening once a week, then I would say, maybe give it a month to see if it works. Because if it's only happening once a week, if you try it for a week, it could just be a really good week. So I usually say start with 5 milligrams. If that isn't enough, you can go up to 10. Usually at anything above 10, I haven't really seen too much benefit with. So that's kind of the point where then we would go to using something like clonazepam.
I was just going to add that I tend to use a bilayered melatonin as well. So there is one that has immediate release as well as extended release. So bilayered sometimes your problem isn't falling asleep, it's staying asleep, and that longer acting melatonin can help with that sometimes.
I have a hard time sleeping for many years, and then I realized that it probably is related to Parkinson. And then I started taking the levodopa, and I have a stronger dosage. And then I realized that if the dosage is stronger, actually I couldn't sleep. And then I quit taking levodopa. And recently I started doing fairly small dosage in 3 times a day and have a better sleep. But I'm questioning the timing of the levodopa. Should I take it before sleep, right before sleep, or many hours before sleeping? Because sleeping is probably #1 challenge for my current status of Parkinson's disease. So thank you.
Yeah, I would say most often when we increase those dopamine levels, it can cause a little bit of kind of somnolence or tiredness. But sometimes if that level is too high and people get kind of, start to get dyskinesias, that can sometimes interfere with sleep. So if, what I'm usually telling my patients is listen to your body and kind of use that, we kind of use that to guide. So if you take it right at bedtime and you're somebody who has a hard time falling asleep, then what I would say is, maybe back it, take it closer to dinner time and give it more time to kind of reach its peak and then start to, kind of on the back end to see if that might help. And then even some of the longer acting formulations that may have a more kind of subtle rise, but more prolonged benefits may also be another option as well.
I have also found that different carbidopa-levodopa formulations, people respond to different. So some people who take Rotari, which is like carbidopa-levodopa, find that more stimulating, where other people find it more drowsy. So I think it's highly individualized too, as far as how you respond to the medication and adjusting it how you respond versus a generalized recommendation.
My question is about constipation and diarrhea. If you have diarrhea, I've heard you mention before it can be a symptom of constipation. How do you know if it's the symptom of constipation or just diarrhea?
So the diarrhea associated with constipation, you'll probably feel more constipated and you probably won't have bowel movements, where diarrhea, true diarrhea, will probably be more frequent, several times a day. However, you still can have it. Also, the consistency matters too. If it is the diarrhea caused from constipation, a lot of times it's more liquidy, clear liquidy, and comes out almost in a big burst, basically, than regular diarrhea.
Hi, I just had a question regarding the PD generation study. I was part of it, and I was wondering, dependent on the genes they tested and what you were positive for, is there a difference in progression or severity of non-motor symptoms?
So that is a fabulous question, and that is part of the reason why studies like PD generation are going on, to better answer that question. I'd say we do know there are some trends where certain genetic forms of Parkinson's disease may tend to behave a little bit more one way or another, maybe more likely to cause cognitive changes than others. Even one genetic mutation, there's a study out that, the cognition, maybe is more affected by things like deep brain stimulation surgery than other non-genetic forms or other genetic forms. So this is something that we are learning more about. We have some ideas, but just like everything else, you can't pigeonhole anybody into anything. And so, genetics of Parkinson's are also tricky in that, a lot of the genetic causes of Parkinson's, even if you have that mutation, you might not even get Parkinson's disease, actually. It's more of a risk factor. So it's interesting. I think it will be useful how we study and potentially how we treat Parkinson's disease moving forward. But I would say having a known genetic mutation is not necessarily a roadmap for how things are going to work for you.
I'm interested that Dr. Jackowiak, you mentioned that there's a PD generation study going on. It actually is at Froedtert Hospital, and I'm actually signed up to participate in it. I would like to know how much research is going on in the local area here in our hospital programs, whether it be Milwaukee or Madison, UW system. We hear a lot about Parkinson's, but we don't hear a lot about the kind of research that's being done in our area here that we could participate in as patients.
Yeah, I can speak about UW. There's a few observational studies that are going on, and as far as the exact details on them, what I would say is that usually what I talk with my patients about is getting them in touch with our research coordinator to kind of really go over the specific details. As far as, kind of looking at disease modifying treatments, so those that will actually slow or hopefully stop the progression. And we do have one study ongoing that's recruiting right now with a tyrosine kinase inhibitor called Inhibicase. That one is only recruiting newly diagnosed cases who haven't been on any treatment at all. And I think the commitment is, I want to say, 14 weeks or so.
Yeah, so in Milwaukee, I think our group, we have, again, there are trials or there are studies that are testing treatments, testing, medications. So we have several clinical trials ongoing now. These tend to come and go, so the trials open and they close, so that it's kind of a brief window, and then that will end, and then we'll get new trials come through. So this is kind of a constantly changing thing, so it's good to always kind of ask your doctor or kind of check back in as to what's going on. So we have a couple going on that are, looking for people who are more newly or recently diagnosed who haven't been started on medications yet that are testing new compounds. We have another that's testing a medication for people who have more advanced disease, so have, where their medicines kick in and wear off, or having the dyskinesia, the extra movements. So just looking at different specific issues that we're trying to treat with the target medication. And then also just non-medication trials too. So you mentioned that we are a site for the PD generation study, which is done through the Parkinson's Foundation, but we are a site for that. You'll also have the opportunity to see Dr. Hassan speak later today. So he's a gastroenterologist who is doing some research in speech and swallowing function in Parkinson's disease at our institution also. And then, we have a neuroscience research center too that has a group of more basic science researchers, more lab bench research that is going on also. So there's a mix of things, but I always say, there's so much going on in Parkinson's disease research, that's outside of our immediate area. So it's good to look beyond our immediate borders here, and see what else is out there. So clinicaltrials.gov is the kind of main site that keeps track, or where you can search for these. Other foundations have, good sites that you can look and, put in information about yourself and see what trials are out there, what you might be eligible for. So like Michael J. Fox Foundation has a trial finder. So there are definitely plenty of opportunities to participate in research if that's something you're interested in.
I think we have our last question.
Hi, I was recently diagnosed. Hi, Dr. Nagle. I just have more of a comment than a question. Why didn't anybody talk about exercise as a treatment for motor and non-motor symptoms?
So if you look back, staying active was actually a lot of what I had put for constipation, as well as doing those muscle exercises, marching in place, as well for the constipation and helping with that too. So yes, exercise, exercise, exercise. You'll probably hear us at every visit talk about how are you staying active, what are you doing, and we do refer to physical therapy quite often because it is so important.
Yeah, that is really important as medical people that we promote the exercise just as much as we promote the medication. And that's why we bring you here today too, right? Is to bring you together with other people who are also newly diagnosed, or maybe you've had Parkinson's for a long time and you know well that that exercise really is key to staying well and doing well, and especially for balance. We don't have any magic beans for balance. That's really about exercise and core strength and movement. So I appreciate you all and all your questions. We're actually going to stop right there because I'm sure we could probably go on all day. So I would like to, again, let's give a round of applause to our three experts. Thank you all so much. I'll let you go step down. Thank you.